I'm going to start today with the common exposures. My goal is to get us all on the same page and talk about a few resources that I hope will be useful to you. Just administratively, before I get going, for the conference evaluation, the code for this session is HS12E. And for those of you who need to get continuing education credits for your state EMS licensure, you want to talk to Bart over there, raising his hand in the red shirt. He will set you right up. So with that, let me go ahead and talk for a bit about common exposures. I am the director of the Occupational and Environmental Medicine Training Program at Johns Hopkins in the Bloomberg School of Public Health, and we've had an association with the International Association of Firefighters for more than 30 years. Our residents rotate at the union headquarters in Washington, D.C. for 2 months in the second year of the program. And I've been involved then with the IAFF since I rotated there in the early 1990s. And I continue to precept residents who are there currently. One of the activities that we did a couple years ago was to update the infectious diseases website. And so I'm going to start today by talking to you a bit about that website. I'm then going to talk briefly about infection basics to make sure we're all on the same page. I'm going to give you some helpful resources for updating exposure control plans or writing them if you by chance do not have one. I'm going to focus on prevention and specifically aspects of prevention that I think may be new to you, such as some NIOSH research on ambulance ventilation. We'll talk about just a couple examples of pathogens and data relating to firefighters. We'll talk about presumptive legislation if you have to deal with workers' compensation aspects, and then resources. So first, the website. The address is here. There are several parts to the website, starting with infection control policy, including plan components, worker training, etc. Infection principles or basics. Practices for prevention, including personal protective equipment and activities such as hand hygiene. There's a big section on diseases. That's where the residents and I worked, did most of our efforts 2 years ago, so that you can link to a whole number of different diseases, find out basics about the disease, and also information about how workers are impacted by the disease. So how you can protect yourselves, what kind of equipment, vaccinations, what kind of post-exposure evaluation you would need. So we've pulled information from the Centers for Disease Control on the diseases themselves. We've pulled information from OSHA on how they impact workers, and we've pulled information from NIOSH, again, on how they impact workers and research to protect yourself. There's relevant standards, like NFPA 1981, for infection control, and then the OSHA bloodborne pathogen standard. And then resources, shared exposure control plans from other jurisdictions that can be helpful as you update yours. So first I want to just briefly mention why this is relevant for firefighters and EMS. I think it's pretty clear, but you work in very poorly controlled settings. Lots of emergencies with opportunities for very uncontrolled exposures. And you may have exposures in the back of ambulances that hopefully you'll find out about, but you might not. So we clearly want to focus on that. Just in terms of data to understand about risk, the 2011 NFPA injury report noted more than 9,000 exposures to communicable diseases, which worked out to 1 for every 2,000 runs. Now, most occupational reporting is underreported, and so it's likely that that was much, much higher. A national survey done by NIOSH of paramedics a decade ago found that 1 in 5 reported at least one exposure to blood in the past year. So that's pretty significant. So with that in mind, let's do a few basics. Pathogen categories. So we're all fairly familiar with bacteria causing infection. There are many that will do this, but I've highlighted MRSA and TB here as examples because we're going to talk about them later in the talk since they have relevant concerns for firefighters and EMS. Bacteria are treated with antibiotics, although there's concern over emerging resistance, and thus we want to really reserve antibiotics for situations in which they're clearly going to be beneficial. Fortunately, many bacteria are now vaccine preventable, and so it's very important to use vaccinations when they are available and appropriate. Another big category of infectious agents are the viruses, which range from things as benign as the common cold to chronic viral infections such as HIV or hepatitis B and C, to the coronaviruses, which have been involved in some of these new outbreaks, such as SARS 10 years ago, and the current Middle East respiratory syndrome, which Captain Spar will talk about shortly. In contrast to bacteria, antibiotics are not helpful for viruses. And so we want to not be treating viruses with antibiotics. There are some antivirals that can be useful. Vaccine development for some viruses has been more problematic, and HIV is a great example in that regard. We're still struggling with a vaccine. In contrast, though, the vaccine for hepatitis B is excellent, something you all want to have had. Fungi are another category of pathogen. One that comes to mind is coccidioidomycosis, which is the cause of valley fever, which is on the rise now in the southwestern U.S. We're not exactly sure why it's on the rise. And then there are some less common infections such as parasites and prions and mad cow disease that we don't think as much about in the U.S., not as common. When are you infected and when are you simply exposed? So if you come in contact with an infectious agent, you have been exposed. If it is on your skin, you have abraded skin. If you inhale it, you have been exposed. It may or may not set up an infection in your body. If it does develop into an infection in your body, it may be full-blown or it may be latent. We use tuberculosis as our example of latent because your body's immune system can react to it, and if we detect that reaction, we can treat you with various medications to prevent the risk of pneumonia from tuberculosis down the road. Risk of infection is going to depend on factors such as the amount of the organism that enters the body, which is dose, the virulence or strength of the organism, and resistance of the host. Obviously, immunocompromised individuals are most at risk there. Now, in terms of modes of transmission, so I think we're all aware that if blood containing a viral, bloodborne pathogen, for example, comes in contact with cut or abraded skin on a first responder, that's a direct transmission. That's a direct exposure. But you can also have a contact transmission that's indirect if your skin, your abraded skin, comes in contact with blood on equipment, as opposed to directly from the patient. We also think about inhalational exposures. So we think about droplet transmission, and this is generally in the respiratory tract. A patient coughs or sneezes and sends droplets of infectious particles out into the air. There are a number of infections that can be transmitted this way. SARS is one that got a great deal of attention 10 years ago, and it taught us a lot because the SARS epidemic taught us that we used to think 3 feet was the safe radius. It's not clear that's true anymore, and it's more likely to be 6 to as great as 10 feet, at which you can still be exposed via droplet transmission, meaning that the back of an ambulance is an area that we need to pay a great deal of attention to, and in fact, NIOSH is researching at this point. Finally, there's airborne transmission, and this is the most worrisome. These are agents that the patient can cough, can leave the area, and they're still there floating around. So that's a problem. It does not require direct contact. Fortunately, not as many agents can be transmitted purely via airborne. Those that do this, though, include Mycobacterium tuberculosis, and so we're going to talk a little bit about ambulance ventilation in relation to that, as well as measles and chickenpox. So this is, you want to think about special air handling and ventilation systems, and in fact, that's now common in hospitals. Okay, so NFPA 1581, and there was a typo on my first slide where I mentioned different number, but 1581 is the standard on fire department infection control programs. And the program components are going to include a written policy, which is an opportunity to sit down and make sure that all aspects of the program are covered in your organization. That involves risk planning. Where's the risk? It involves training and education of workers, and I think that's a critically important piece. I find that a very rewarding part of my contact with workers when I'm doing physical exams for them. It requires an infection control officer. That's a very key role because that's the person who's going to make the whole program work and make sure all the pieces are in place. There's a lot of data that have to be monitored within an infection control program, including a database of all exposures, of all vaccinations needed and given, and of any responses that are needed post-exposure. All right, so a lot of information that needs to be kept track of and medical care provided. NIOSH also has a document on the basic elements of an exposure control plan for bloodborne pathogens. So this is a more specific plan, but the components are very, very similar. The vaccine that is the focus here is hepatitis B, of course. And one thing I want to note that's specifically mentioned in the NIOSH document is annual plan updates. So in addition to other data that you want to keep track of for record keeping, they talk about SHARP's injury logs, training records, and plan updates. And the updates are an opportunity for you to look at your group's experience over the course of the past year and say, okay, where did I have my exposures, or where did my group have their exposures? What lessons can we learn from it to prevent that going forward? So it's a great public health opportunity. Now, if you think about developing written plans, that's a lot of work. Does everyone in the room have some type of written plan at this point? You've all got it pretty much? Great. Okay. Should you need to add any pieces to it? Should you want to look at it and see how comprehensive it is? There's a couple resources for you here. The first is OSHA's sample or model plan for bloodborne pathogens. So this is a fill-in-the-blank form that makes sure you're compliant with OSHA. They also have a form, for example, if a worker refuses the hepatitis B vaccine. You want to document that. Now, before you would document, you would find out why they're refusing and make sure it's not because they've been misinformed that they're going to catch some infection from it. Then, the IAFF website for infectious diseases has plans that organizations have generously shared. So Austin, Texas, Columbia, South Carolina, and the state of New Jersey have their plans up there. So it's really nice, rather than reinventing the wheel, you can see what others have done. Other resources include the U.S. Fire Administration Guide to Managing an Emergency Service Infection Control Program with specific attention to vehicles and facility considerations that are going to be unique for EMS. There are a few keys to setting up an effective program to protect workers. Now, this is not just unique to infectious diseases. When setting up any program to protect workers, it is critical to involve the workers, the management, and the healthcare providers, and get them all together working on setting the plan up and moving forward. Why? Because if the medical folks and the workers are not interacting, they're not going to be understanding opportunities for prevention for the workers. Worker involvement affords an opportunity to select the best safety devices for that particular setting, disseminates rationale for vaccinations, and corrects misinformation. So there's a lot out there that vaccines can cause autism or that the hepatitis B vaccine can cause HIV. It's not true. Vaccines are one of the most important things we can do for prevention. So we want to get that message out there loud and clear, and having everyone on the same page in a group effort is a great way of doing that. Now, the IAFF Infectious Diseases website talks about practices and PPE. I'm not going to dwell on that because I think you all know it, but I do want to point out that IAFF recommends a NIOSH-approved P100 disposable respirator rather than an N95 for additional protection. There's also information in the CDC guidelines for preventing the transmission of Mycobacterium tuberculosis that specifically talks about ambulance ventilation. The goal here is to have airflow from the patient away from the healthcare providers to expose as few people as possible. An enclosed cab will do that so that folks up front are not exposed. Having fans operating, and if possible using a recirculating ventilation unit with a HEPA filter so that you're actually cleaning the air going through it. And I've listed the resource for you here for that. Other key prevention steps: keep those vaccinations up to date, and the OSHA bloodborne pathogen standard now requires checking titers to see if workers who have received the hepatitis B vaccine series responded. Those titers are to be checked within 1 to 3 months after the third dose of the vaccine. And the reason you want to do this is because about 10% of people who are vaccinated as adults do not respond. That 10% includes people who are older, more obese, and smokers. And you want to know who those folks are because the titers naturally decline with age. That does not mean that you're not going to respond if you're exposed to hepatitis B down the road if you responded to the vaccine initially. And so this shows you CDC recommendations and shows you what gets done if you are exposed, for example, to a needle stick that has hepatitis B surface antigen positivity. So if someone has been vaccinated and they're a known responder, it's okay. You don't need any treatment. In contrast, if you're a known non-responder, you're going to get immune globulin and either revaccination or more immune globulin. What if you don't know whether you responded or not? Well, then you're going to get titered. They're going to draw your blood and check and see if you've got any antibodies. But you probably won't, depending on how long ago your vaccine occurred, because they naturally decline with age. And so if you don't, then you don't really know whether your body's going to mount a response or whether it's not. So then you end up, if your titers are low, getting immune globulin. So this circumvents that step if you know your response in the first place. Okay. So then I want to talk a little bit about NIOSH research. This is another prevention aspect. And this is within the back of ambulances. And so NIOSH right now is currently working on evaluating ventilation patterns within ambulances using surrogate tracer techniques. Where does the airflow go? They've developed a model so that they can use various experiments to do this on a regular basis and try and figure out the best approach. And finally, they're interested in taking technology using ultraviolet irradiation, which has been used now in hospital rooms, to adapt in the smaller setting of an ambulance. All right. Next, we're going to talk about specific examples. I'm going to talk about bloodborne pathogens, which I suspect you know a bit about, but we have specific data in paramedics that I want to share with you. And then I want to talk about methicillin resistance, Staphylococcus aureus, again, a concern in firefighters and EMS. So a decade ago, NIOSH did a survey looking at paramedics and found, as I had mentioned before, that 1 in 5 had had exposure to blood in the past year. But interestingly, California paramedics, half that rate. And we think that's because California passed a needle stick prevention law several years before the national law. They also have a higher use, or had a higher use at that time, of safety devices. So it's kind of nice to see that connection between public health policy and protection. The survey found that Sharp's injury rates were higher compared to hospital workers, and they called the exposure in broken skin, quote, extremely high from their survey. They were also concerned that they found underreporting. In fact, only about a third of exposures to broken skin were reported. Paramedics said they didn't report if they didn't think the exposure was significant, and this was especially true for broken skin, or if they thought it was their fault. So one of the prevention recommendations from NIOSH in this document was to emphasize reporting. Report every bloodborne contact, whether it's eyes, nose, mouth, broken skin, or a needle stick. Report it. It turns out that HIV and hepatitis B and C have all been reported to be transmitted through broken skin. So that is a viable option. It's not as, the risk isn't as great as if you get a needle stick with a large bore needle, but it's still there. HIV post-exposure prophylaxis needs to be started ASAP. Undiagnosed workers are a source of infection, so we want to know about that, and it provides essential information to protect coworkers. So we think about injuries and illness at work as the tip of the iceberg. The person who has it then illustrates risk for their coworkers. So reporting is absolutely critical. Other aspects is it turns out that paramedics reported fewer exposures if their supervisors were on board, if you had top-down involvement and safety was made a priority. Okay, let's talk a little bit about MRSA. Staph aureus that is resistant to methicillin, what this is a bacteria that normally infects the skin but is resistant to most of the bacteria we normally use on the skin. Things like penicillin and amoxicillin and methicillin, quite resistant. So this is a problem. We worry about the skin infections, which can be, the abscess in the center to being really quite severe, and these are both from CDC's website. The other concern is that particularly in hospitalized patients, the MRSA bacteria can infect other organs. And so you can have pneumonia. You can have sepsis, which is the bloodstream infection, and then infection in other organs. Community acquired generally are of the skin, but it can be a big problem. I mean, you saw that hand picture. MRSA can be transmitted from person to person and, more importantly, from surfaces to people, and it lasts and stays alive and viable on surfaces for days to even longer. And I couldn't find a good scientific endpoint for how long, potentially weeks. So that's an area of active research. So in addition to standard precautions, you have to think about handling contaminated equipment and laundry, isolation rooms for MRSA-infected patients, just like we do for TB-infected patients, cleaning off visible contaminants and then disinfecting them for equipment. And at this point, CDC says there's no evidence that spraying or fogging entire rooms or surfaces with disinfectants is helpful. You're going to focus your efforts. Now, what's the impact of MRSA in firefighters? Well, there have been a few studies conducted to date. One in Tucson found that about 7% of 160 sites sampled had MRSA contamination. Particularly at risk were couches made of soft, porous material. Interestingly, they didn't find a lot of MRSA on surfaces in trucks, but in contrast, two other studies, one in Maine, did find MRSA contamination within trucks. Another study found paramedics had nasal colonization with MRSA at twice the rate of the general public, suggesting of occupational risk. Now, Dr. Marilyn Roberts has done research in Washington State firefighters, and that is ongoing. Do we have any Washington State folks here this afternoon? Okay. That's ongoing research, but her pilot study, she's got a wealth of information on her website, so I want to refer you to that because I'm going to talk about that in the next couple of slides. Her pilot study found sampling 9 different areas in fire stations from the apparatus bay and vehicles into the living quarters that 4.1% of samples had MRSA, and the same strains were in the trucks as in the living quarters. So it suggests to you a path into the living quarters. And she found, rather surprisingly, nasal carriage rates of 22%. So that's clearly higher than the general public. So she's now doing a follow-up study, a larger study for this. But in the meantime, she has a MRSA fact sheet on her website for how to maintain a clean zone in the living quarters of the fire station. And it involves things such as hand washing, targeted disinfection, areas such as doorknobs, light switches, places where your hands are going to go frequently. Keeping living quarters at positive pressure to the apparatus bay, which makes sense for diesel exhaust too. Mats at the entrance into the living quarters, so you wipe off your feet and you clean those mats. Replacing soft surfaces with hard surfaces, which are easier to clean. Washing bedding and then cleanable covers on electronics. And then finally, I want to finish up with presumptive legislation. Vermont, with Dr. Lidow's help and Matt Vincey's help, passed their presumptive legislation for infectious diseases just this year. It includes firefighters and EMS, and they are covered with workers' compensation for disability or death resulting from infectious diseases caused by aerosolized or airborne infectious agents, or bloodborne pathogens, or those acquired after exposure in the line of duty. And I also want to alert you to the California IAFF website, where they actually have text from 3 relevant infectious disease laws that they've passed. So that should be very useful as well if you want to do something along the same lines. Just to finish up, resources. The infectious disease website at IAFF, as I mentioned, and then really the Centers for Disease Control has a wealth of information on the diseases, on the vaccines, and for healthcare workers. So that concludes the slides that I have. We have time for 1 or maybe 2 questions, if anyone has questions. Thank you. To have had a response, you're good to go. There's no recommendation at this point for a booster. I keep waiting thinking that's going to change, but it hasn't yet. One more question? Yes.
If you didn't have your initial titer and you've had years go by, is it recommended in terms of costing that you go and have the titer to see if you did have a reaction?
Really? You're shaking your head yes. I was going to say no.
Well, I guess there was some spirited discussion on one of our professional, we call it the Duke list, a while ago. So if you don't have your titer or you lost your titer, we can draw a titer for the reasons that Dr. Weaver was describing, because you want to know, and I want to know as someone who's treating you, what to do if you get stuck by a needle.
So I was getting to that third step, that if you save that step, so is that from a cost-benefit analysis, is it worth saving that cost?
Well, here's the thing. So we'll do a titer on you, and you may have been, in the past, one of those 10% who didn't react. So it's difficult to tell at a later time, well, are you one of those that didn't react, or did you just miss the opportunity to get the titer? So we may end up giving you 3 more doses of vaccine, which is what's recommended for people who don't respond the first time. But again, the cost of treating you for hepatitis B or giving you 2 very uncomfortable doses of immunoglobulin after a needle stick is definitely mitigated by 3 more doses.
Okay, good, thank you.
Okay. All right. Okay.
I just have a question about hepatitis C vaccination. Is it, put it this way, I got the first 2.
Hepatitis B, you mean?
C.
There isn't a Hep C vaccine.
I got some type of hepatitis vaccination.
That's B, or maybe A.
It was 3 iterations of
That's B.
vaccinations. And the second vaccination that I got basically made my entire arm go into pain for like weeks before I got the vaccination. And I had no adverse symptoms. But I never went back for the 3rd vaccination because I didn't really
Right. Right.
So if I was to go get revaccinated, would I have to go take 3 more vaccinations again?
If I were you, I would just have your post-exposure evaluation. If you get exposed to hepatitis B infected blood, have your titers drawn at that point, because it would have been great, given the reaction you had, to have been titered right at that point, because there's, I think, like a 70% response rate with 2. So you might have already responded. Right. So there is a, not a, you know, it's not as high, but, so you might have already responded, but you don't have any way of knowing that. So, I mean, I guess, given that reaction, I would.
She just said, well, you probably have an immunity now.
Was in the U.S. Navy for 15 years, and so she has had a lot of information and a lot of experience with biological warfare agents. And just before she left the Navy, she was the deputy director of the Occupational and Environmental Medicine Training Program at the Uniformed Services University of the Health Sciences. Since that time, she directed an occupational health clinic and now has her own consulting company, and she has faculty appointments at UCSF and at Johns Hopkins. So thank you so much, Dr. Lipp.
Thank you. So courtesy of the Philadelphia Fire Department, I took a snapshot of their decon unit, which I was describing in the previous session, embarrassed my children to no end. But they had it out at the 4th of July, as the firefighters explained to me, in case anybody did anything stupid. So one of the reasons, other than a shout out to Philadelphia, that I include this picture is just so that I can emphasize the point that this is part of the new normal. It's now normal to not necessarily expect, but to anticipate and to pre-plan for the just-in cases of a use of a weapon of mass destruction at any big public event like the July 4th celebration in Philadelphia. So there are 3 categories in general of chem-bio and radiation terrorism agents. So I just wanted to touch on them for completion. We're going to be focusing this afternoon on the bioterrorism agents, but there are also chemical agents, which could include nerve agents, choking agents, and some people may have heard of blood agents as well. And then under radiologic agents, we could have dirty bombs and improvised explosive devices. The CDC classifies agents that could be used as weapons of mass destruction for bioterrorism as Class A. That's the most dangerous, the baddest actors, if you will. Things that are easy to spread, easy to disseminate, including those that are very efficiently passed from person to person. And also agents that have a high potential for high fatalities or high mortality if they were used as a weapon. Class B are the agents that are less easy to spread than Class A, would cause less morbidity, less illness, and are less likely to cause fatalities. And Class B includes ricin toxin, and we'll be discussing that this afternoon. I'm not going to discuss any of the Class C agents, but those include emerging infectious diseases such as hantavirus that have not yet risen to the potential of a Class B or a Class A agent. So there are 6 Class A agents, and then we're also going to discuss ricin. So in order, smallpox, which is variola virus or caused by variola virus, and this is a picture of an unfortunate gentleman that had disseminated smallpox. The good news about smallpox is that we thought we were done with it. The last case was in the late 40s, and in 1977, I think we declared smallpox eradicated, but we still have some, and so do some other people. So we need to be aware of the smallpox because it is so contagious and can cause up to a 1 in 3 or 30% mortality. Is very concerning illness. Smallpox is highly contagious via respiratory droplets, just as Dr. Weaver was explaining. This is transmission person to person through small droplets of either coughed substances or saliva, mucus fluid. And again, as she had stated, we don't know the safe zone for transmission. Smallpox is also transmitted through contact with fluid from the blister lesions or the pustules that people have when they break out in this rash, as well as contact with contaminated bedding. And we know historically there are some stories of folks that were giving away contaminated blankets in an attempt to purposely infect certain populations with smallpox. The incubation period of smallpox ranges from 7 to 17 days with an average of about 12 days or 2 weeks. And after an incubation period, people will start feeling sick. We call this a viral prodrome. They have fevers, muscle aches, and then they develop a rash. And the lesions of the rash start first in the mouth and in the throat. And then when someone develops these lesions, that's the point at which they are the most contagious. And that rash then moves to the skin, where we see red bumps, which then turn into what we call pustules or little fluid-filled blisters. And then these lesions eventually scab over, though the people are contagious until they all fall off. And one thing that we can use to distinguish smallpox from chickenpox, which also causes little fluid-filled blisters, is that when you have chickenpox, you can have these lesions in different stages at the same time on your body. So you can have some little red bumps and some of these fluid-filled pustules, and then some lesions that have already gone and scabbed over. But people who have smallpox, all of their lesions are in the same stage at the same time. And if you go to the CDC website, you can look at various teaching tools and diagrams which try to help folks distinguish between other diseases that cause rashes like smallpox and that chickenpox and measles with the disease of smallpox. There is a vaccine available for smallpox. It's important to note that although this is a live virus vaccine, it is made with vaccinia, which is not smallpox, so you cannot get smallpox from the smallpox vaccine. There are certain people who can't get the smallpox vaccine, and those would include people who are immune compromised, people who have certain skin conditions, and very young children and infants. There is no PEP or post-exposure prophylaxis for smallpox. And just to expand on what Dr. Weaver said, so post-exposure prophylaxis is medication that you take to reduce your risk of developing an infectious disease after exposure. So for some of the Class A agents, there is recommended post-exposure prophylaxis. Unfortunately for smallpox, it being a virus, we don't have an antibiotic agent that we can give you. We do, however, have a vaccine that we can give you to protect you, and if you are on a smallpox response team, then you may be someone who would be vaccinated. There are antiviral medications that could be used in the case of patients with smallpox. Our next disease is anthrax, which is caused by a bacteria, Bacillus anthracis, and that's a picture of him. The unique thing about anthrax that many of you may recall from fall of 2001 is that anthrax can be in a spore form, like a dried powder. And furthermore, if someone were to try to weaponize this, they are trying to create a particle that can last in a dried state that could very efficiently be inhaled and then penetrate to the deepest tissues of the lungs. So this would be a very manufactured, very high-grade special form of anthrax. Because you have this dried spore form, it can be relatively easier to, say, spray over a geographic area, or as we saw in 2001, to be delivered in a package or a device that is designed to spray it upon opening. We do have a vaccine for anthrax. It's a multi-dose vaccine that then you get 4 doses in the first 6 months, and then at intervals you do need booster doses to maintain your protection. This is not a live vaccine, so again, you can't get anthrax from the anthrax vaccine. Because of the risk of anthrax, the skin form of anthrax, to veterinarians and animal handlers, and this was mentioned in the previous talk, even cattle, we have been giving anthrax vaccine for many years to veterinarians and animal handlers. And so we have a lot of experience with this vaccine, and we're very confident in its safety. When anthrax is in this weaponized form and then is inhaled, unfortunately, there's about a 75% risk of death or mortality without treatment. Incubation for an inhaled exposure to anthrax usually lasts less than a week, but we know from our experience in 2001 and since then that you can have people exposed who don't develop symptoms for up to 2 months later. The symptoms start with a flu-like illness that can be followed by respiratory distress, which can advance to the point where people need ventilatory support. And in 2001, we had a lot of what I call the worried well, because the anthrax attacks occurred during flu season. I don't know if anybody remembers that. So we have a lot of people who are very concerned, do they have the flu or do they have anthrax? And the CDC has maintained resources on its website so that if you do need to counsel people or educate them about the difference between a cold or the flu and anthrax, you have some resources. Fortunately, anthrax is not spread person to person. If you are exposed, the post-exposure prophylaxis is either ciprofloxacin or doxycycline antibiotics, and that's going to be a theme song as I go through the rest of my slides. So one of the good things about bioterrorism agents is you don't have to remember that many antibiotics. Our next disease is botulism, and this is a picture of Clostridium botulinum, which is the bacteria responsible for it. We know a lot about botulism because it's generally caused by ingesting food that's gone bad. It's food poisoning. Unfortunately, infants are particularly susceptible to this, and we've had instances of infants who've been poisoned with bad food or honey products. There are a lot of cautions about what infants can eat safely. When we have botulism or muscle paralysis that's due to an exposure from eating or ingestion, symptoms can take up to 5 days to occur. But when you have an inhalation exposure, the symptoms can onset much sooner, within 12 to 72 hours after inhalation. And again, this would occur if someone were to weaponize this so that it were spread and people would be inhaling it rather than ingesting it. So we would see people with double vision, trouble swallowing, trouble speaking, and ultimately paralysis of their breathing or respiratory muscles. Uniquely, these people don't have fever, and that's kind of one thing that perhaps could let us discern this from other infections that would cause paralysis. Botulism is not spread person to person. We do have an antitoxin, which you can get via state health, from the CDC via state health departments. And the latest guidance to people who are treating potential cases of botulism is that although there are lab tests to confirm, we don't wait for confirmation. We treat based on symptoms. In March 2013, the FDA approved botulism antitoxin heptavalent, and this is now going to become part of our strategic national stockpile so that we will have a supply of this antitoxin to use in the event of a bioterrorism incident using botulism. Next, we have plague, which is caused by the bacteria Yersinia pestis. We do see incidences of skin plague or bubonic plague. Those are caused by exposure to animals. When we talk about a disease that would be related to bioterrorism, we're talking about pneumonic or lung plague, which can result in fever, headache, pneumonia, ultimately shock, and unfortunately has a near 100% fatality rate without treatment. The bioterrorism exposure would be inhalation. This is transmitted from person to person by respiratory droplets, so again, it's quite concerning. And symptoms can arise within 1 to 6 days of exposure. The good news, especially for first responders, is that there is effective post-exposure prophylaxis. So even though this is quite contagious, if you were exposed to someone who ultimately then was diagnosed with pneumonic plague, you can be treated with antibiotics successfully. Tularemia is also called rabbit fever, and it is caused by bacteria Francisella tularensis. Symptoms of tularemia include fever, muscle aches, pneumonia, and weakness. Good news, it's not spread person to person. Again, the bioterrorism method of exposure would be inhalation. Symptoms often occur within 3 to 5 days after exposure, but could be up to 2 weeks. And tularemia's unique is that there is a slower progression and a lower case fatality rate compared to plague or anthrax. But as promised, you can see that the post-exposure prophylaxis is our two friends now, doxycycline and ciprofloxacin. The last category A agent that I will be discussing includes the viral hemorrhagic fevers, and two of them are Ebola and Marburg agents, which are RNA viruses. Fortunately, we don't see these diseases in the United States. We've learned about them through outbreaks in Africa. The viral hemorrhagic fevers cause fever, muscle aches, fatigue, notably bleeding, and this can be bleeding from every orifice and bleeding in the eyes and the mouth. It's actually quite notable, although people don't necessarily die because of the bleeding. There's a very high case fatality rate for these diseases, up to and over 90%. We don't have any treatment for them other than supportive care, although some infections have responded to antiviral agents. And these are very contagious and are transmitted rather than through respiratory droplets like some of the other diseases we've been talking about. These are transmitted via contact. So contact with blood, contact with body fluids of people who are infected, and even contact with tissue pathological specimens or remains, the bodies of people who had succumbed to these diseases. The respiratory transmission is possible and has occurred under research conditions, but we haven't had examples of it during outbreaks yet. Unfortunately, we don't have a vaccine for these viruses, nor do we have any post-exposure prophylaxis, so you can imagine that something like this used as a bioweapon could be pretty disastrous. And in the lower right-hand corner, for those of you who are familiar with Mickey, that is an electron micrograph of Ebola. So now we're going to move on to the one category B agent that I was asked to discuss today, and that's ricin toxin, and we've certainly had a lot about this in the news lately. Ricin toxin can be made from castor beans. At the cell level, it inhibits cell protein synthesis, so it disables the cell. The health effects depend on the route of exposure, and I'll discuss those in a minute. Ricin toxicity is not transmitted person to person. We'll see symptoms in 4 to 24 hours depending upon the method of exposure, and death can occur within 36 to 72 hours. And you remember when I told you that category A agents were more likely to cause fatalities, so it was kind of confusing to me that ricin was a B. I tried to find some estimation of the chance of fatality with exposure, and I was not able to find that. So I can surmise that the reason that this is a category B agent and not a category A agent is because of the relative difficulty in taking ricin toxin and making it into a bioweapon. So if you get exposed by inhalation, then the first effects, as expected, would be on the respiratory tract, so shortness of breath, fever, cough, pulmonary edema or fluid in the lungs, and then shock. Whereas if you were to ingest ricin toxin, you would expect the first effects on the gastrointestinal tract, so nausea, vomiting, diarrhea, resulting in dehydration, seizures, and then multi-organ system failure. Health effects are unlikely after a skin exposure, but as like with many other toxicants, if you have skin exposure, then you can ingest it because your hands are contaminated, and then you're perhaps picking up food or touching your mouth, as we all do. And the ricin toxin itself can be a skin irritant. We don't really have great treatment for ricin exposure. We have supportive care. If the exposure is ingestion, we can do a charcoal lavage to try and remove the toxin, and we don't have a vaccine or any post-exposure prophylaxis. So I'm now going to move on to just a brief discussion of recommendations for use of protective clothing, personal protective equipment, and respirators. And on your desks, on your tables there, you have some of the monographs that I've listed in the resources, which will be at the end of the presentation. As well, Judy from NIOSH was kind enough to give me some hard copies of specific recommendations for protecting EMS providers. And they also include, on page 35, some discussion about decontamination. So those are actually on the back table, or you can look them up on the internet. And a lot of the information on these slides is going to be similar because in instances that are the highest risk, where we don't know the agent, we don't know the concentration, it's an uncontrolled event, we don't know if the exposure is still continuing, and we may not know the dissemination method, then the highest level of protection is indicated, and that makes sense. So that would be SCBA and level A. In the situation in the second bullet where there might have been an aerosolization and the event is now over, then we may be able to go to level B with an exposed or an enclosed NIOSH-approved pressure demand SCBA. In a situation that is very controlled, such as the package that can be easily contained, then a full face piece respirator with a P100 filter or a powered air purifying respirator with a HEPA filter might be indicated, again in the circumstance where you have a very well controlled exposure and you don't have ongoing wide dissemination of an airborne agent. Recently, we've had specific recommendations for personal protective equipment for ricin and anthrax, for ricin SCBA with a level A protective clothing, as well as a polyethylene suit for personnel that are doing decon, including eye protection. And then in 2012, the federal government updated recommendations for the case of a widespread anthrax attack. We had some interim recommendations in 2001 and 2012. We have the latest update of them, and they look a lot like the recommendations on the previous page. For the highest risk situations, such as a chem bioradiological or a nuclear self-contained breathing apparatus would be indicated, again, if you had an ongoing release or when the specific agent was unknown. But then if you had a less serious exposure scenario, as I mentioned on the previous slide, you might be able to go to level B. Again, in the case of an unknown agent or an unknown situation where you don't know where it's being dispersed from, or is this what the agent is, it makes sense to always use the highest level of personal protective equipment. And I just wanted to touch on decontamination a little bit. You're all familiar with the various zones and the concept that we're trying to move from the hot zone or the area of highest contamination through an orderly process to make sure that we are not contaminating our outer zones or our cold zone. And in the previous hour, I just told an anecdote. I was overseas in the fall of 2001 and had the frustrating experience of running decon and supervising the activities of our first responders, and multiple times we had ambulances drive right through the hot zone. And then I had another 4 people to decon. And it's kind of really looks bad, when you have the Italian authorities and everybody wondering what the hell you're doing. So it is important to try and, as usual, control the situation and have a orderly flow and monitor your decon and educate people so that they're not well-meaningly driving through contaminated areas and creating more patients, if you will. Decontamination is exhibited here in the picture there. Those are folks drilling on a decon line. You can see they're spraying water, and although that kind of looks like they're hitting the guy with the broom, it's a soft brush. So soft brushes are recommended. Again, I mentioned the potential for ricin itself to be a skin irritant, and Dr. Weaver mentioned the skin as a route for contaminants and certainly bloodborne pathogens to enter. So we don't want to create a skin injury with our decon. We do, it's natural to really want to get somebody very clean, but we use soft brushes and a less than vigorous amount of scrubbing so that we're not creating another route of exposure for the bioterrorism agents. So here's just a few key take-home points. Again, as I was discussing, and it makes sense that if you don't know what you're dealing with and you don't know if dissemination is still going on, you wear the highest level of personal protective equipment, which would be a level A with an SCBA. This is the new normal, and we need to maintain a high level of suspicion. If we are not maintaining a high level of suspicion and awareness and communication, then we don't know that we have to prepare. And this is especially important because, as I've mentioned, many of these diseases look like other diseases. How many times did I mention a flu-like illness? So, you're going on a run for somebody with the flu, or it's anthrax, or it's smallpox. So, not to alarm you, but it is important to realize that a lot of these things look like stuff that we are a lot more comfortable with. And these diseases can also have extended incubation periods so that we may not be aware. Now, certainly if there are unusual clusters of illnesses or if there is an ongoing awareness for a particular illness, that might raise your awareness. Good news is anthrax, botulism, tularemia, and ricin toxicity are not contagious person to person. And you cannot get smallpox from the smallpox vaccine, nor can you get anthrax from the anthrax vaccine. And my last slide just has a summary of resources. Again, just commercial for the CDC bioterrorism site is a wonderful site. It has useful slides that you can use, perhaps most useful in training. It has handouts you can give people that are directed for EMS personnel. They have handouts that are directed towards the general public. So if you do need to educate people, especially in an emergency event, you don't need to create your own risk communication information. You can go to the CDC website, get familiar with it in advance so that you know that you're going to be able to produce information very quickly. So I'll take a couple of questions. Is that okay? Anybody have a question? Yes?
Why does Ebola seem to come and go? I mean, you'll hear about it, it's around for a month, and then it's like it comes and it goes.
Yeah, and the CDC has a new subpart of their site for viral hemorrhagic fever. So if you go on the bioterrorism website now, it migrates you over to this other site. Part of it is what I would say the CNN effect. You know, if it's a slow news day, viral hemorrhagic fevers are kind of sexy. You know, unfortunately, there's a big ongoing problem in Africa with viral hemorrhagic fever outbreaks.
So it's not going away.
It's not going away. And you know, the scary scenario is somebody who is that sick getting on an airplane. So you're welcome. Yes.
When you're using the garment, level A garment, are you referring to a 1991 style garment or a 92 garment that's fully encapsulated?
Fully encapsulated.
So you're not necessarily referencing to a 91 style, NFPA 91 style garment.
And again, I don't want to mess up the terminology, so I'll just state we're talking about fully encapsulated, you know, even where you might be, you know, maybe duct taping your gloves and your sleeves. And again, skin contamination and small particles of toxicants might be more of a concern in terms of a chemical event than a biological event, but we're still trying to afford that highest level of protection.
What about this new push about using pH-adjusted bleach?
You know, when we first started doing decon, it was bleach, 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 bleach. So I was slightly surprised when I looked up the most updated guidelines for this talk. And again, that's one of the reasons why I provided you the OSHA NIOSH monograph, because it is soap and water. And so we've kind of moved away now. For stuff, there is a low concentration, or that, you know, you mix up some concentrated bleach and water. That is still a recommendation, but for people, the recommendation is soap and water. And I would refer you actually to the, let me see if I can give you, here, the OSHA monograph is probably the latest guidance about how long and how much water, and they even go into specific devices for water streaming and water pressure to make sure that it's effective amounts of decontamination. Yes?
I have 3 questions for you.
I'll see.
Botulism. And do you have any, in your opinion, do you think botulism could be deployed as a dry particulate aerosol at some point?
It's funny, with students, I say I put my mad scientist hat on, and you know, I'm just speaking for me here. I'm not speaking like with a security clearance or anything. I don't have any super secret knowledge access anymore. So, you know, the botulism, we know most of it from food poisoning. So that there's a theory that, and obviously based on some mad scientist type lab research and trying to anticipate what the bad guys might do. So I don't know the recipe for it, but I can tell you the reason that it is in class A or as one of those agents is because it is possible and feasible. So yeah, now, I guess part of my role is not to alarm you, but there is a reason why those agents are there. Yeah. One more question, Dr. Weaver says.
Persian Gulf.
Mm-hmm.
Do you have any familiarity with Persian Gulf syndrome, and can you talk to health effects, etc.?
I would say my email address is in the abstract, and I would be happy if you sent me an email, and then we.
The reason I ask is because I've got 3 medical doctors right in front of me. I've been having gastrointestinal symptoms for years and years and years.
Right, and I would say
I've been involved. I'm actually in the Persian Gulf syndrome, you know,
Okay.
World Trade Center health show.
Right, and I would say it's outside the scope of this panel right now, but I'm happy to help you on an individual basis as well. I think Dr. Weaver mentioned we do have a senior resident at the IAFF who is tasked with advocating and trying to get the best knowledge possible.
Just like if there's been any adverse effects from taking Cipro on a repeated basis, because I've taken Cipro on a repeated basis.
Not that I know of.
All right. Dr.
Okay.
Little, thank you so much. I
You're welcome.
appreciate it. Okay. So next up is Captain Spar. And let me introduce you. So, Captain Spar is a commissioned officer in the U.S. Public Health Service, and he is the Associate Director of NIOSH's Office of Emergency Preparedness and Response, so he's ideally suited for this upcoming talk. He has been a commissioned officer for more than 30 years, and he was also in the Division of Safety Research, where he conducted research at NIOSH as well. So that's an additional aspect that he'll bring to this talk. So Captain Spar, thank you so very much.
Thank you. And I'd also like to thank the IAFF for their gracious invitation and sponsoring this workshop. There's a lot of good information out there, and a lot of it is piled right in front of you. There's probably more handout material in this session than any other here at the Redmond. Also, I'd like to thank you for coming to the last session, listening to the last speaker on the last day, and so I'm grateful for that. Most of you are probably either safety officers, infection control officers in your units. You're probably very familiar with the safety officers' guidelines on occupational health. You've probably read the NFPA standards until you've gone blind. So I'm not going to talk about those. I'm going to talk about something a little bit different, and I brought you a different reference item. So in your pile is an APIC guide. This is a brand new 2013 Association for Professionals in Infection Control guideline for EMS. And if you would humor me, just circle in the table of contents Section 6 and Section 7. This contains everything that you've heard today, but in great detail, and it's written down. And this, I gave you a copy of it. I know it's small print because I had to carry these here from Atlanta. But this is a free document. It's downloadable as a PDF from the apic.org website, and I'll reference it here in the presentation. So I'm going to be talking about this manual as I go along. I'm going to give you some references to sort of check and follow me as we go. IAFF asked NIOSH to be a part of this panel because they wanted us to just give a quick update on the Ryan White Act, what's happened since 2009 when Congress reauthorized the Ryan White Act. Is everybody familiar with the Ryan White Act? Is there anyone here that's not familiar with it? This is the news. It's a reauthorization. The 2009 was a reauthorization of the original 1990 Ryan White Act. This is essentially the HIV grants program that the federal government put together. It's a $2 billion a year grants program. The Congress sends money to the states use this money to treat people with HIV and other bloodborne pathogens, and they use it to fund vaccine research and modern day research. But there was a component in the original Ryan White Act that talked about life-threatening diseases that emergency responders might be exposed to. And so it was built into this act specifically to give more information and a protection factor to emergency responders. So what this act does is it creates a disease list that did not exist before and gives you the right to ask for information about your potential exposures to something that might be deadly in your workplace. We needed this act and this particular component of it because the existing OSHA laws aren't that broad. They don't cover very many infectious diseases. The Ryan White Act gives you a comprehensive list of diseases that you might be exposed to. Further, it's specific to it. It covers workers, occupational groups that the OSHA standard does not cover. How many people in the room are state employees? How many of you are volunteer firefighters? How many of you are municipal workers? Okay, OSHA laws don't apply to those three groups. But the Ryan White Act does. It's a national regulation now. So this Ryan White Act is important to you. It's something that benefits you. It lowers the cost of health care to first responders. It provides reasonable rules and regulations and time frames, and it specifically benefits the following occupational groups: firefighters, EMS, USAR, hazardous materials, and police and correction officers. So it's a benefit to you. What Congress wanted the CDC to do, and NIOSH in particular, was to come up with a disease list, which we did. And the original disease list, which came out in 1994, contained only a few deadly diseases. But note that on this list, since our theme at this workshop is bioterrorism, there's actually 2 bioterrorism agents in the original Ryan White list. You'll note plague and viral hemorrhagic fevers. What NIOSH did in 2010, in the late into the years, we put together a blue ribbon panel. We came up with a new list. We took the old list and we added to it. And what we added to the old list were these additions, which also include a couple other bioterrorism agents. You'll see anthrax. You also see smallpox on there. But we specifically added a transmission mode to cover select agents. These are the bioterrorism agents that we were just talking about, the Class A, Class B, Class C agents. Now, in the DOD and the FBI and the law enforcement world, they use that classification, A, B, C, and D. But today in the Department of Agriculture and in the HHS and the CDC, we don't usually use that classification system. It's there. It will always be there. But today we call this something different. We call these select agents. And I'll give you a little bit more information about that in just a second. So what's new in the Ryan White Act is we paid attention to public comments. When we created the revised list, we asked for public comment. There was one comment that we got that talked about that the Ryan White potentially life-threatening disease list needed to have bioterrorism agents added to it. We thought about that, and we thought that comment was absolutely correct. So we added it, and that was a new step for us because the ones that are on the disease list, smallpox, anthrax, pneumonic plague, these can be transmitted person to person. That's why they were on the original list. But other bioterrorism agents may not necessarily be transmitted person to person, but which may contaminate you during doing your work. So we had to not only add bioterrorism agents to the list, we had to expand what exposed meant. How do you define being exposed? And so we added the bioterrorism agents, and we also expanded the exposure definition to include select agents that you may be exposed to either from a contaminated surface or an environment that you go into. Let's just think about that for 1 second. Let's say we have an anthrax attack right over here on 16th Street in the mall area there. You roll up as the Denver Fire Department and EMS crew, and they've already set up a perimeter. There's bodies in there. There's people thrashing and wrathing around. You need to go in there and extract those people. So you may go into that environment. Just by going into that environment, you may contaminate yourself. You grab that patient, you put them on a gurney, you take them to the ambulance. The people inside the ambulance can also have that anthrax re-aerosolized and affect them. Then it goes to the emergency department where the first receivers get them. The emergency department is working 2 or 3 shifts a day with all these patients coming in, so every new doctor that comes into the ER could also be potentially exposed. So exposed, in this case, covers that entire spectrum of exposure. So that's why the Ryan White Act was expanded. We wanted to add that atypical pathway that bioterrorism agents present. So bioterrorism agents can be referred to in a lot of different ways. You can call them select agents, bioterrorism agents. Some people call them BSATs, biological select agents and toxins. And there's even another term we'll learn here in just a minute. But what makes them scary, as was mentioned before, is that they can be weaponized. You can make them much more lethal. You can make them be resistant to medical care and treatment. You can make them smaller and in high concentrations that you would not find in nature. So this makes these very powerful agents of terrorism. So we've expanded the Ryan White Act, and in October of 2012, the Federal Register put that into writing, and so now the Ryan White Act references select agents. Those are these bioterrorism agents that can affect humans, including toxins, and they also includes those that affect animals and agriculture, and those that overlap all three of those. But what the CDC did is when they put this back into the Federal Register, they relabeled it one more time. So instead of being a Class A agent or a BSAT, they called them Tier 1 agents. So Tier 1 agents, this is the new term, this is the new thing in the Ryan White Act, is a reference to Tier 1 agents. Tier 1 agents are the same thing as the Class A agents in the law enforcement world, but in the agriculture and public health world, we're now kind of referring to those as Tier 1 agents. I colored them brown because these are the bad boys. This is the poo that we may have to respond to in the workplace. So you need to educate yourself on these kinds of agents, the worst of the worst, those with the highest risk of being used as potential terrorism agents are those that are highlighted in brown. The Ryan White Act has been up for 2 years now. We average about 500 web hits a month. I get about 2 phone calls and 2 emails every month. If you have a Ryan White question and you want to learn more about these Tier 1 agents, or you want to learn about the disease list and what's on the list and what's not on the list, what are infection control officers supposed to do, you can call us, you can write us, or you can email us. And if you call us, I'm the guy that answers the phone. So if you have a Ryan White question and you call the Ryan White helpline number and I answer the phone, say, hey, Jim, here's my question, and I'll give you the best answer I can get for you. But if you do use the email or a letter, particularly if you use the email, be sure to identify yourself. Leave your name, leave your phone number, or leave your email address so that we can get back in contact with you. This is an automated system, so if you email us, there's no way for us to email you back. I have to personally be able to read your request and then respond directly to you, so leave me some contact information. I'm going to switch from Ryan White and bioterrorism agents to the other thing that the IAFF asked us to talk about. When they were planning this conference, there were some emerging potential outbreaks that looked like they might become pandemic. And in particular, in the early spring this year, there was a poultry outbreak in China. How many people have heard about H7N9? Okay. The IAFFs wanted us to just give you some quick highlights on that, and they also wanted us to talk about this new coronavirus, which is very similar to the SARS virus that today we're calling MERS, or MERS-CoV. That's the Middle East Respiratory Disease Syndrome. So I'm going to give you a little information about that. But before I start going down that rabbit hole, remember there's a difference in terminology here between outbreak and pandemic. And that's why I put the WHO curve on there. You'll see that there's a spectrum of, illness that's represented in that diagram. You go from an in-between pandemic phase to an alert phase to a full pandemic. And what a full pandemic means is that there is high levels of human-to-human transmission and usually a highly lethal form of transmission. So actually the WHO has 6 levels of pandemic phases, and we're not anywhere near any of those for the outbreaks that I'm going to talk about today. Today we're going to talk a little bit about H7 and a little bit about MERS. These are still in an outbreak status. They have not reached a pandemic status. We're in the alert stage for those 2 pathogens. Often I'm going to go back for a second. Often you hear about seasonal influenza and swine flu and avian flu or bird flu. These are seasonal, they happen all the time, and they happen domestically in the United States. But the 2 we're going to talk about today, we don't have any H7 and we don't have any MERS in the United States. So this is all precautionary. This is all a potential, this is something just to worry about, to make ourselves better educated about. But currently there are no threats in the U.S. for these 2 outbreaks. Normally, when the CDC is focused on monitoring for outbreaks, because an outbreak will lead to a pandemic, they're always keeping our eye on what's going on in the world. We're doing surveillance, we're improving our epidemiology tools, we're enhancing our laboratory techniques. This is normal pandemic preparedness. But when a real pandemic occurs, the CDC kicks into an activation mode, which is quite different. And for both H7, that's an avian flu, it's a DNA flu that's in China, it's in a couple other Southeast Asia countries as well, but it's predominantly in China. I lost my track there, so I'm going to just start over again. When a real pandemic occurs, and those two diseases that I've been talking about are indicators of something that might turn into a pandemic, the CDC activates. And when they activate, they go into specific strategies to prepare for a pandemic. And what I have on the slide are the preparedness steps that then get kicked in when an outbreak occurs. If an outbreak looks very dangerous, we start doing these things. We start trying to get samples of that virus so that we can see if we can turn it into a vaccine. We try to build new laboratory test kits that we can give to the hospitals so that they can do a nasal swab or take a blood sample and we can identify whether you have that virus or not. We get that live virus from wherever that outbreak occurs, we transport it to the CDC, and we inject it into certain lab animals to see what's the nature of the pathogenic effect of that virus in their body systems. And we will get blood samples just to see if people have a titer, an antibody response to it. Is there an immune response? What's the nature of that response? Are there any viral agents that will help reduce that outbreak? We need to get human blood samples from those outbreak areas. And so when the CDC activates for a potential pandemic, we kick in all these extra measures rather than just the normal pandemic preparedness. SARS and MERS are interesting to us, and the CDC activated. We, just like you do in your command centers in your county and your city, where you have a command center that activates and all the mayor and all the civic leaders come in and all the fire chiefs and the police captain, they all come together and they start controlling the situation through their emergency operations center. The CDC does the same thing. We activate when there's a particular outbreak on the horizon that looks serious. Outbreaks that look serious have these three major characteristics. There's some kind of an associated unknown about them that means they could be potentially very dangerous. There's some unknown laboratory questions that have to be answered. And there may be a particular vulnerable population that may be affected by the outbreak. Now, H7 is exactly that. H7N9 is an avian virus that's strange, not because it's a common avian virus, but because normally this virus, H7, will kill poultry. They don't normally kill humans. And in this case, in China, in these live bird markets, a trend developed. There were these people that farm these animals and sell these animals in the marketplace. They're sold live, or among cooks and people that prepare this poultry for eating. They come down with this disease, and there was a high percentage of a higher risk of death. So that set off our CDC alarm bells. And H7 is only unique because it presented in a way that is atypical. Instead of killing birds, it's starting to kill people. It's not affecting the birds. The birds haven't died off. And this is because all viruses present this genetic evolution problem for public health. Each of these different bird groups can exchange viruses, and as those viruses are exchanged, they recombine and they evolve, they mutate, and they create a new virus. And so this diagram, sort of in a diagram fashion, shows you how genetic components from ducks and quails and chickens get mixed up, and then they become pathogenic, and they can be transposed to humans. In the case of H7, we're no longer activated on H7 because we found a good vaccine candidate for it. And right now we're beginning to produce a new vaccine for this particular virus. So the CDC still maintains a lot of guidance and information about H7, but over the summer it's been shown to be a very difficult disease to transmit from human to human. Only that vulnerable population group seems to be exposed. Good quarantine measures in China, cleaning the environment with bleach helped knock down that infection among the poultry workers. And so today it's not so much of a risk. So the CDC says, keep yourself up to date, keep your eye on these emerging pathogens. And if you're a person that goes to China, just be careful about, handling wild animals and make sure you cook your chicken. I mean, it's pretty common sense. So there's nothing special about infection control measures for the H7 poultry virus in China. MERS, on the other hand, is a little bit more complex type of a viral agent. It's a coronavirus. It's called corona. That relates to the crown image that the virus presents. You can see it kind of looks like a crown on a head. The corona means crown, so that's why it's called a coronavirus. This is a beta coronavirus. They're not very common in humans. They're in a diverse number of animals. But since 2003, we started out we didn't even know, but 2 of these viruses could be transmitted to humans. Since 2003, MERS is now the 6th example of a coronavirus that's gone from a zoonotic infectious disease agent to a human pathogen. This one's really strange because in H7, let me go back one more. You see, there was this genetic drift that occurred in poultry, and then it moved to humans. And so quails, ducks, and chickens were the animal host. In MERS, we don't know what the animal host is. We're still uncertain. It appears to be a bat-like virus, common in bats in Africa, but it can also be found in civets. That's a wild cat that's common in Africa, and it can transfer between those animals, but there's another vector in there somewhere that we haven't identified. We don't know a lot about this disease. It's rather worrisome to virologists because we don't know its origin, we don't know the reservoir where it's coming from. We really don't know the full extent of how it presents itself in humans. We don't know what kind of a viral shedding pattern it creates in humans. It's like SARS, but it's way different from SARS. SARS was another coronavirus that occurred in 2003. It emerged in China, spread to North America. That was a much more deadlier virus. It killed 900 people and made 8,000 people sick between 2003 and 2004. But MERS is not that way. It hasn't killed that many people, but those that get this disease, it's SARS-like in the extent that it's deadly. But with MERS, it's even a faster onset of pneumonia. It's different than SARS. It's a little bit worse than SARS. But it's also very difficult to transmit from human to human. H7, it was really hard to transmit from human to human. You had to be handling poultry to get that infection. MERS is capable of being spread from human to human, but it just is not spreading efficiently. It's not a virus that evolved to the state where it's a really effective virus in the human body. It's still a kind of an archaic. It needs to evolve some more. Still needs to add some more genetic components before it's going to become super lethal. Or it may not. It may just die out. We're hoping that it'll just die out. Like I say, it's related to bats. We've discovered that camels have an immune response to it. Camels were infected at one time, but they've built up resistance to it. But none of the people in Saudi Arabia that's had this disease were exposed to bats or camels. So we still are mystified as to where the natural reservoir is. The big problem about MERS is that it is communicable between people. And so people who travel to Saudi Arabia and the 4 countries where it's a little bit more common are at risk. And so I wanted to talk a little bit about what the CDC recommends for travelers and for healthcare providers in particular, and then EMS staff in specific. The big problem in the Middle East is there are many pilgrims that go there for religious reasons. The faithful Islamic practitioners will try to go to Mecca at least twice in their life. People that can afford to go more than once will go during Ramadan, which we just left the month of Ramadan on August 7th. Usually the people that go to Umrah go there voluntarily. They will go because they can afford to go. They're usually younger, more wealthy, have less comorbidity and disease, chronic disease conditions. So they're the more healthier people that would go during that time. On the other hand, in October comes the Hajj. The Hajj is the pinnacle of Muslim faith. Those true believers believe they have to go at least once in their life. So every Muslim will try to go to Mecca once in their life. And so usually they save up a lot of money. They go when they're older. They go when they have kidney disease and diabetes and comorbidities. And so it's a sicker cohort that goes to the Hajj. A younger cohort and a more healthier cohort go to the Umrah. So we're still a little bit worried about pilgrimages to the Middle East, and particularly to Saudi Arabia, where Mecca is. So the Kingdom of Saudi Arabia has said that they would like people who are planning to go on the Hajj to talk about that with their healthcare provider. If you're greater than 65, if you're younger than 12, if you have cancer, any terminal illnesses, you have an immune-compromised system, you should delay or postpone your trip to the kingdom. So CDC's guidelines for people traveling to the Middle East are be careful. If you travel there and all of a sudden within 14 days of coming back you come down with a flu-like set of symptoms, report that to your healthcare provider. Be sure to tell them that you were in those geographic locations. Also, practice good personal hygiene, and if you're sick, isolate yourself, don't go to work. So this is the common guidance for travelers. For healthcare workers, we have a set of interim guidance. We kicked it up a notch. We added some specific guidance for first responders and doctors and nurses that provide direct patient care, like in an ICU. We've kicked it up to standard contact and airborne precautions. And let me just note that airborne precaution means that an EMS technician who's carrying a suspect patient in their ambulance should have their eye protection on and an N95. If they suspect that patient has got a poor hygiene, they're coughing a lot, put a medical surgical mask on that patient. That's called source control. When you don a respirator, that's an occupational health infection control measure. If you put it on the patient, that's source control. So for medical transport workers, the CDC does have specific guidance. Make sure that you follow standard precautions, wash your hands, follow contact precautions, wear appropriate PPE, and especially protect your eyes and wear an N95 equivalent or better respirator. Now, respirators are problematic. We learned during H1N1, which was an avian influenza that we had in 2005, that the supply of N95s will quickly be exhausted. There will be geographic areas where the supply runs out faster. So there'll be shortages all over the United States in certain locations. So the CDC recognizes that in a pandemic outbreak, when things go beyond this outbreak mode to a much more severe, much more human-to-human, faster transmission modality, we need to have some guidelines for healthcare providers. And so we've set up 6 priorities. NIOSH is recommending now that hospitals take this time in between the acute phase and the pandemic phase to do things like this. We say, look at your hospital, change the HVAC system, change the way you take patients in, make it a little bit harder for people to come in direct contact with the healthcare workers. We also say that consider buying, if you're a healthcare organization or you're a fire department or EMS crew, consider buying other types of respirators. There's various respirators that are the equivalent of an N95 filtering face piece. You can have a PAPR. You can have a half-face elastomeric with HEPA filters. There's other things out there other than just N95, so add that to your inventory. We're also suggesting that before a pandemic occurs, and starting now, it's probably a good idea to build up a 120-day stockpile. We're saying, get yourself a 4-month supply and build that into your inventory system. We're thinking that people should have expanded guidelines on use and extended use and reuse and decon of respirators. So those guidelines are coming soon. And further, we want to work with the FDA to have expedited clearance of all types of respirators during a pandemic. Right now, routinely, hospitals will only wear FDA-approved respirators, but there are many other types of respirators that aren't FDA-approved that do the same job. So in summary, don't get in a panic over H7 or MERS right now. It's still an isolated outbreak. It's not a pandemic. Educate yourself about these emerging themes. Understand how viruses mutate and the natural cause of things. Take some, appreciate the fact that the federal government really is working to help you, and that we do have an activation mode that we kick in to increase the development of vaccines, to increase test methods, to increase the supply of respirators. If you travel, be careful. I noted here on the slide how you can download this full manual. It's free. It's a PDF from the APIC website. The address is at the bottom of the slide. So lastly, there's a couple of things I didn't mention but I do want to emphasize. One is sick leave, a lenient sick leave policy in your units. Kathleen Sebelius, the HHS Secretary, really recommends that human resource leaders build this into your pandemic preparedness plan. Have lenient leave. Even though you are critical workers, there have to be enough of you to do your critical service. So having lenient sick leave, not infecting your coworkers, is really important. Now I know that in a firehouse, that's a trick, but it's for other businesses, it's not so much of a trick. And then lastly, we are developing new vaccines all the time, and so it's really important that you get your annual flu shot. Do you know when you should have your flu shot? Well, what we say is get it as soon as it's available or by October. So I invented this little saying, every time there's a new fiscal year, get your flu shot. So October is the beginning of the fiscal year. There will be some additional information that comes out that will all be risk-based, but an important thing is to continue to educate yourself, and that's the benefit of the Redmond and Barbera Symposium. So thank you for your attention, and if you have any questions, I'll try to answer them.